vascular surgery really was as an F1 for the last 4 months, so I'm not quite as knowledgeable as Jake. I apologise in advance, but I'll do my best to answer any questions. Okay, so basically we're just going to go through 5 big things. So aneurysms, acute limb ischemia, and chronic limb ischemia, which I kind of like to think of acute limb ischemia as kind of like your acute MI, like it's an occlusion, and then your chronic limb ischemia is more like your stable angina, it's unstable. And then ulcerations, which I think comes up a lot, particularly in clinical examinations, where I'll be asking about which types of ulcerations are indicative of which, and then veins, which hardly ever comes up, but I thought we'd go through varicosities just in case. Okay, so aneurysms, your definition is greater than 1.5 dilatation of original diameter. So, for example, your abdominal aorta, sort of 2 to 3 centimetres in the average person, so it would be more than 3 centimetres is normally considered an aneurysm in your aorta, and then 5 centimetres is when it's really significant. So a true aneurysm is involvement of all layers of the vessel wall. So anyone know the layers of the vessel wall? Yeah, intermedia and external. And then false, which is much more unusual, is a collection of blood around the vessel wall that communicates with the lumen. So any ideas when you get a false aneurysm? Yeah, intravenous drug use is one that happens a lot. Generally people aren't very good at injecting their own groins and tend to miss, and it's important if you ever feel a lump in somebody's groin that's pulsating, especially if they're intravenous drug user, the most important thing to do is get an ultrasound to exclude a pseudoaneurysm, because it's normally an abscess, but it's very important just to rule it out because it's quite dangerous. And then types of true aneurysm. So there are just 2 of them, fusiform. So I'm going to do a picture afterwards, but it's kind of like a all the way around dilation on both sides. And a vascular, so they'd be the aneurysms you get in your brain for aneurysm. Anyone think of any other type of true aneurysm? It doesn't come up a lot, but it's something that people tend to know about. It's dissecting aneurysms or true aneurysms. Anyone know anything about dissecting aneurysms? Classification? So this is something I've only had in MCQs, that's why I didn't put it in. So dissecting aneurysms commonly involve your aorta. If they're before your left subclavian, they're type A aneurysms, and if they're after, they're type B. It's the Stanford classification. I didn't put it in because it's not something that comes up a lot, but occasionally it comes up in MCQs, and their management's very different, because type A is managed surgically, and type B is managed medically, just with blood pressure control. They're relatively common. So this is the second aneurysm here, it's further along, but first of all, vascular, so that's your berry aneurysm. Then fusiform, that's your typical shape of an abdominal aortic aneurysm. And then dissecting, it's like a split, so a weakness in the vessel wall, and blood passes down one side. So as you can imagine, if they happen in the first arch of your aorta, they can be very dangerous. They can be very dangerous anywhere, but they're more likely to rupture in the first half before your left subclavian, which is why they're managed surgically. Afterwards, if you manage to control their blood pressure well enough, not that much blood is going to come into the gap. So if you reduce your blood pressure to within sort of, normally they aim for less than 120, it's less likely to be serious and rupture. And then false aneurysm is your intravenous drug user, or any other reason why you get a false aneurysm. Sorry, I think you might have said and didn't hear. Things that we do to people. So angiograms, a lot of access is through, and you can get radial false aneurysms as well for coronary angiography. Okay, so your risk factors, as I said before, this has a lot in common with coronary artery disease. So congenital aneurysms are your connective tissue disorders, say big risk factors for abdominal aneurysms. And then your required are like your classic like coronary artery stuff. So modifiable things like smoking, high blood pressure, atherosclerosis, which is really more simple disease than a modifiable risk factor, and hyperlipidemia as well. And then, like coronary artery disease, male sex and increasing age. Family history, kind of related to congenital and kind of related to your risk factors, hyperlipidemia. And then if you have a popliteal aneurysm, it's always important if you feel a palpitating aneurysm, to rule out whether or not they have a coexisting aortic aneurysm or an iliac aneurysm, because they're at a higher risk. So, the big complications, so rupture, one everybody knows about, thrombosis. If you have typically the fusiform aneurysms, because you have the two dilated pouches on either side, the majority of the blood comes through the middle, and you get like a stagnation on either side of the fusiform, and that's why you get like atherosclerosis in there, and you can get embolisms later on, but we'll go through acute ischemia. And then, yeah, distal embolism, so that's why you get that with the atherosclerosis on either side. And then compression of adjacent structures. Not so much in your aorta, but you have a big femoral aneurysm, so you might get compression of your femoral nerve, but it's not something that's particularly common. So this is a, what is this? Is that somewhere? Yeah, it's ultrasound. So this is the screening test that one-off ultrasounds offered to men over 65 years. It's not been in place very long. I actually don't know when they brought it in, but it's done at the minute. So as I said, normal aorta is 2 centimeters, un-ruptured aneurysm 3. That's a very broad classification. There is some individual variation, like small women will have smaller aortas than big massive men, so it's kind of just a general. And then 90% are either in between your renal arteries or below your renal arteries. It's very unusual to get one above. So, the next bit's a case, but it relates a little bit to this. Oh, sorry, it's not. So, the medical management of an unruptured aneurysm. Do you know when you would start to think about managing? Yeah, that's sort of always the cutoff for surgery and things. Before that, you just want to look at these things, your modifiable risk factors. And do you know what an EBAR is? Yeah, so it's a endovascular aneurysm repair, done quite commonly and increasing in use, particularly in LGI, it's doing a lot, and then open repairs, so under general. The advantages and benefits, EBAR tend to be done in old, clapped out people who wouldn't be suitable for a big aortic aneurysm repair that's open, but as an emergency, a lot of the time people aren't suitable for the EBAR, so somebody comes in an ambulance brought in with a suspected AAA because of hypovolemic or unstable, they'll generally be brought straight to theatre for an open repair still. It's a little bit because that's what's done out of hours and what the consultants at the minute are still comfortable with, so that might change in the next 10 or 15 years that they do EBARs all day every day. But and then surgery, as ever, is risky, so it's only done when the risk outweighs the benefits, which is typically the 5 centimeters. So I think the risk of rupture at 5 centimeters is something like 5% a year, and then increases exponentially from there as the aneurysm gets bigger, but you're put into a monitoring scheme. And then open repair report in younger adults, which has longer, you can get away for longer without having a recurrence or any complications of a stent graft, which is what would happen this. So, just put in a couple of clinical cases just to highlight the point, but 65-year-old male, probably your typical aneurysm patient, same as your typical cardiac patient, same risk factors, same diseases really. Presented A&E, sudden onset abdominal pain, median to the back, sweaty, clammy and unwell, likely to be hemodynamically unstable, low BP, tachycardic. A lot of the time, do you know what they do in the ambulances or when they're on the way, how to decide where to take them? If somebody has a history of aneurysm, they'll basically take them to the aneurysm hospital, which is a basic thing. And then once they get to A&E, if they haven't come to aneurysm hospital, they fast scan them. So a lot of the A&E consultants will be quite adept at ultrasounds, and they'll do an ultrasound while they're still in A&E resus, and then they can get them straight there. Because a couple of times whenever patients get sent to acute surgical units, they get missed and managed as hypovolemic or septic, and then they're it's very unlikely that they'll make it because mortality is 50% even if you get to theatre, so it's not great odds. So that's your classic rupture AAA. And man over 55, woman over 70. 70 is, it's cardiac, so you've got the preventive estrogen factors, reducing your atherosclerosis, things like that. And then your history is your turn, pack pain, might be central abdominal pain, but a lot of the time it goes straight through, and then hypovolemic shock. Expantile abdominal mass might not be there by the time you see them. They might be so clapped out that they don't have any expansion. And then they're clammy, sweaty, syncope. And yeah, still a really high mortality. Oh, rubbish. Sorry. The management of ruptured AAA. Yeah, standard. So it's ABCDE and really wide bore cannulas. Do you know how many units you'd cross match for somebody if it's often ruptured? Yeah. So each, and then what would you do? What's the most important thing to do? What's that? Fluids? Yeah. Well, I'll tell you get the blood, but what do you need to do that can definitively change how this person, whether they live or die? Yeah, like you can't do anything, so all you have to do is let somebody know. So that's it, basically. If you get time to do an ECG, that'd be good, but I don't know. And then get in the theatre. And if you're in doubt about it, emergency ultrasound, but a lot of the time, as I said, these are done in A&E. Okay, so second case is a 70-year-old lady who presents at A&E with a 24-hour history of a painful, pale and cold right foot. She's known AF with a metallic aortic valve. So what's the likely diagnosis? Yeah, and how would this be treated? Yeah, ABCDE, but do you know anything on top of that? What would you do after? Yeah, the molecular right, which sounds scary as a principle, something to do, but it's actually, in practice, it's really simple. I've got lots of very clear charts to tell you exactly what to do if you haven't seen one before. So acute limb ischemia is a surgical emergency. Nerve cells die of ischemia after 6 hours and needs prompt intervention. So it's the same with the aneurysms, let somebody know. Mortality is 22%, amputation rate 16%. So the physiology of it, it's about 50% thrombosis, 50% embolic occlusion. So it's as the thrombosis and plaque rupture. Coronary gain, embolic occlusion is mentioned just a little bit in that case, that you have a lot of risk factors for embolism. So if you have AF, if you have a metallic valve, if you have abdominal aortic aneurysm where stuff's collecting in the sides, go straight down into your foot and you get an ischemic foot. And then compartment syndrome, it's not necessarily something, it's more of a reperfusion injury than anything else. So this is your classic acute ischemic limb. It's not quite as pale as it should be. It's a little bit of a bad projection, but there's a difference between acute and chronic limbs. That acute limbs tend to be pale, chronic limbs tend to be red. So if you get pale, mottled limbs, sudden onset, it's acute. Red limbs, it's kind of semi-acute onset, more likely to be chronic. And then 7Ps, which I'm sure you all know, but I always manage to forget one of them on every occasion. So it's pale, perishing cold, pulseless, reduced refill. Pistol shot onset is more for acute than anything else. Pain, paresthesia and paralysis. And the last two, the worst signs. So if you're not perfusing your limbs so well that you're getting nerve damage and paresthesia, it's likely that you've already got a problem that might be beyond repairing. And then paralysis. So management of acute limb ischemia we already went through, so ABCDE, some painkillers, call a vascular surgeon, and then low molecular weight heparin, generally by infusion.
Why do you need to check the INR and the AP?
It's more just if they're already warfarinized. A lot of people like this will be, if they're embolic, it'll be because they're already in AF. So if you check their INR, you'll have an idea of whether or not they're adequately coagulated, what their kind of risk would have been for this embolic event, or it might give you an idea that it's thrombotic and that their emboli source would be well managed. So it's more of an indication of that than anything else, because you're pretty much always going to put them on heparin. You're not, if they've come in with an acute limb, you're not just going to leave them on warfarin, even if their INR is therapeutic. So it's just an idea of the baseline. And then APTT is the measurement of the heparin, if the whole thing works around your APTT. So embolic cause management and thrombotic cause management are different. So if they're at a high risk of embolic cause, if they've got all these things we mentioned before, like neural thrombosis or anything, you consider thrombolysis. So this is generally done by vascular radiologists. And then if contraindicated, you get an emergency embolectomy where they pass like a catheter down through, if say it's in your foot, and then pull the embolus up. Post-op, anticoagulate, and investigate for the cause. So the ECG is always just for AF. Echo to look for any sort of ventricular thrombi, and then ultrasounds of your aorta, so thrombotic source, femorals and popliteals. Popliteal aneurysms are surprisingly common, it's not something you hear about a lot. Thrombotic cause management, similar to coronary thrombotic causes, angiogram plus balloon or stenting, and if this fails, bypass surgery. I don't know how much you need to know about bypass surgery. I imagine it's not very much. It's basically, if you have a blockage, you pipe around it. So if you've got a blockage in your higher femorals, you do a fem pop. If you've got a blockage higher up, like in your iliacs, you do an iliac. And then if you've got a big aneurysm that's from a mycotic cause, so do you know mycotic aneurysms? I've heard of this before.
Infected.
Yeah, mycotic and infective aneurysm. The most common organisms are salmonella and staph. Really rare, but if you've got it, there's not much they can do about it. So they just try and control the infection. You might resect, it's very rare, and they do an axillary bifemoral, which are quite prone to falling down, like to blocking off, because they're prosthetic grafts generally. They're also quite risky. And then bypass surgery thing, as with all grafts, it's always better to use a homogeneous, so to use a vein, to use something like particularly your long saphenous. And if you have already used your long saphenous for your heart, they'll do a prosthetic graft, plastic. And then maybe acute on chronic. So maybe somebody with a long, like say you have a long-standing angina, then you suddenly rupture a plaque, you're going to get acute on chronic pictures. It's the same. So if you have an atherosclerotic lesion in your femorals, you block it off with a plaque, you're going to get an acute limb ischemia below it, even though you might already have all the symptoms of chronic ischemia. So complications of treatment. So basically reperfusion injuries, if they've been blocked off for quite a long time, they can get damage from dead muscles, so you can get myoglobinemia and AKIs, hyperkalemia for the same reasons. And if it's too far gone, if you've got paralysis and foot drop and you nerve damage, you might end up with amputation, gangrene or compartment syndrome. I haven't went into compartment syndrome in detail. I imagine it's covered something else, but you know what compartment syndrome is? Anybody? Yeah. In the compartments.
Yeah, it's limited by the fascia, so.
Yeah. So you get muscle swelling in response to reperfusion, everything swells up, it's not going anywhere else, it's trapped within the fascia. Treatment? Fasciotomy, okay. So, case 3. 80-year-old man, diabetic, presents with increasingly painful left leg, ulceration and gangrene of his left first toe. Previous history of loss of metatarsal amputation on the right foot. Do you know a metatarsal amputation? You've seen them, they're basically like stump feet, so they take just half of your foot and everything from there is gone, so your whole metatarsal bone. It looks quite unusual. And big risk factors other than diabetes. Hypertension. He's a man.
South Asian.
Somebody say South Asian. Oh, yeah. Sorry, I just wasn't expecting it. Yeah, it's fair enough. Other things? Smoking, hypertension, atherosclerosis, hyperlipidemia, family history, man, diabetic. Diabetic's the big one in these people, like the amount of diabetics and vascular coming with chronic limb ischemia, and you don't know whether the foot is infected or ischemic because their ulcers generally have a kind of mixed picture, and they need antibiotics and reperfusion. Happens a lot. So chronic limb ischemia, almost always atherosclerosis, range from asymptomatic to critical limb ischemia. So if you have critical limb ischemia, rest pain, throughout part of the limb, and this is your classic history. So it starts off, it'll have like 3 or 4 years and getting pain in one of their calves, occasionally when they walk. Then they'll start noticing that it happens a wee bit shorter in distance than it used to. Then they get night pains, they're hanging over the edge of the bed at night, trying to get some blood back into it, and then eventually they'll notice that part of their toe will go a bit dusky, turn a bit brown, they'll not really care too much, and then it'll all go black and come in. So, risk factors, modifiable, we went through, sedentary lifestyle and obesity, risk factors for most things. And then the presentation, so this is the classification system. I'm not sure, like the general principles you'll know, so it's fine, claudicant, rest pain, tissue loss.
Is that just peripheral vascular?
specifically critical ischemia?
Yeah, it's chronic limb ischemia.
Oh.
So claudication is something you only get with the limb ischemia.
No, but what I mean, is it chronic? Is that
Chronic? Yeah, because acute presents more suddenly than that. You're not going to get claudication with an acute limb ischemia because it comes on so quickly that their foot just goes very pale. You don't have the time, unless it's acute on chronic, which obviously is.
Sorry, I don't think I made myself clear.
Yeah, sure.
Intermittent claudication, though, it's that you can have intermittent claudication without chronic limb ischemia.
Oh yeah, that's why it's a range. You have chronic limb ischemia if you have intermittent claudication now, because you've got atherosclerosis in the vessels of your legs, so your muscles aren't perfusing as well as they would be. But that's at the top end of classification. So you can have intermittent claudication all your life, and it'll not go anywhere else, but you'll still be stage 2 on this. Do you understand? Like, you can just be a claudicant and you're fine. You have ischemia just in the same way as you have stable angina. You have a degree of narrowing, but you can be on tablets for it. It'll reduce your risk factors, and you can get 500 yards without any trouble and then get a bit of pain. Do you know what the big differentials are for claudication? Spinal stenosis, and what's different about spinal stenosis? No. It's kind of the big thing about it is what you just did. If you bend over, it goes away. Right? But it can have almost exactly the same picture, which is it turns up at vascular clinics because they're getting claudication back of their legs when they walk, and they're still walking, but it's not going away, and it's really by rest to sit down and lean forward a wee bit. But it's the leaning forward that's the real key thing, is taking the pressure off. And then calf claudication, typically femoral disease, buttock claudication, iliac disease. Although you can get calf claudication with iliac disease as well. It just depends on the level of the blockage. So if you've got iliac disease, you can get buttock and calf claudication. Have you heard of a syndrome involving buttock claudication? It's Leriche syndrome. It's something that just comes up in MCQs, that you get buttock claudication with erectile dysfunction due to disease of your aorta iliacs.
Sorry, what was the name of that?
Leriche. It's Leriche. And then critical limb ischemia, rest pain. So if somebody comes in and says, I've been walking for years like this, it's just been getting gradually worse, and now I can't even sit and it's painful all the time. That's whenever you think about doing something about it. So doing a bypass operation or doing angioplasties. And then if they start using tissue, it's the same. So your typical chronic limb, it's your vascular arterial exam. So they'll have absence or weak pulses. You do from top down, cool limbs, and then atrophic skin changes and hair loss, and punched out painful ulcers, and sunset foot with purple red colour. Do you know why you get the sunset foot and when it happens? It's related to the next point.
Is it hemocyst?
No. It's burgers. It's do you know Burger's angulus, or when it happens? I'm sorry? Yeah.
Because you get paid out dilation.
Yeah, it's a reactive hyperemia. It's your sunset foot. So you do the Burger's test, you lift their leg up like 90 degrees in a normal person's fine, 20 degrees in somebody with a really severe ischemia. It'll get pale, it'll get venous guttering. Then you put it back down, they'll hang it over the edge of the bed, and it'll get bright red because they get blood flow and then a reactive hyperemia. So that's your sunset foot. So you only get it, you don't just get it when the foot's sitting there. Though it does get a bit red, but the real sunset fit's whenever you lift it up and put it back down. And then it can pull your refill greater than 15 seconds. Sometimes with people you can't even get signals with a Doppler. Like, it's a wonder that their foot's still there. So these are some pictures of a chronic limb ischemia. So ulceration just in the forefoot, and then this dusking. So investigations, the one we talk about a lot is ABPI. So do you know how you do an ABPI? I'm sure you've all done one at one point. So brachial over peripheral. And then normals 1, claudication 0.9, 0.6, rest pain 0.3, 0.6, and gangrene 0.3 or less. Then on all of these people you want to do a BM because a lot of them are diabetic, and then urine dip. Just make sure they don't have any severe symptoms, and bloods. The imaging, they do all kinds of imaging in whatever order they fancy most of the time, but typically it's always start with the cheapest first, so ultrasound, then angiography or stent. It'll depend on whether or not, how complex they think the blockage is. A lot of the time, if they'll only do angiography and stenting if they've done an MRI and it shows that there's only one occlusion. Because if you have multiple occlusions in multiple different places, it's better to just do a bypass, because you get better long-term outcomes rather than stenting in 4 different places, one of them going down and having to do the whole thing again. So, but I think it's gold standard treatment. And then CTA if they don't tolerate an MRI, or if they have like a previous metallic stent. So this is your MRI pictures. There's your angiography pictures. I'm not particularly good at the anatomy on MRIs, but if you can see, there's a bit of a occlusion on both sides, about halfway up. And then this is just an angiography picture. So management, depending on your classification within the Fontaine, if you've just got occasional intermittent claudication, you try and reduce their smoking, reduce their weight, get them to exercise more. Sometimes they'll have these monitored exercise programs, so it can improve outcomes. If you're trying to perfuse your muscles more with more exercise, you can get a degree of improvement in the claudication distance. And then treat predisposing conditions, so all your risk factors, antiplatelet agents like clopidogrel, and then ACE inhibitors, even if non-hypertensive, mostly because it affects the management of your likely heart condition. Because ACE inhibitors don't really do much to improve your vascular problem. They just help prevent you from having a heart attack with because if you have chronic limb ischemia, you're going to have some degree of atherothrombotic disease all over your body. And then interventional angioplasties we talked about, and bypass surgery. So, an idea what type of ulceration this is? No. But it is one of the, it would be a descriptive word for this type of ulceration, but do you know what type broadly it is? No.
Arterial.
Yeah, arterial. So arterials also have a punched out appearance. This, I think, is normally arterials and neuropathic ulcers as well are both overpressure areas, so there can be a degree of overlap between them. I think this, she might have had like a tight shoe that was rubbing and then had an ulcer in this area, because they're typically over areas that are getting repeat abuse. And other things that arterial ulcers have, you get granulation at the base. Oh, sorry. This type of ulceration? Venous. Yeah. And anything particular about it that makes you think of venous? Yeah, venous eczema.
Widespread.
Yeah.
Another important thing with venous ulcers is that they generally start above the ankle, and arterial ulcers are generally below. So their location is important. Other things that you get with venous ulcers, different skin changes. Hemosiderin. One more.
They're like flaky.
One more.
Venous eczema?
Yeah. Yeah. And atrophy blanche, which I'm not quite sure exactly what it is. I think your skin just turns a bit white. And this one.
Pressure.
Neuropathic. So, same again, punched out ulcer, likely diabetic or vitamin B12 deficiency, but typically diabetic.
How do you know that's like? Is it just what makes you think to do that from a non-arterial?
It could definitely be in that picture. It could be either over pressure area, punched out, but it's the sort of base of it that makes you think it's arterial, and the history versus neuropathic. So if they've got like a grey, mucky base, the arterial, and then the base of the neuropathic is not as visible, but they might be very deep, because sometimes neuropathic ulcers are related to trauma. So yeah, that's just a table of basically what I just said, and then neuropathic ulcers tend not to be painful, whereas arterial and venous ulcers are painful. Neuropathic ulcers aren't painful because all the nerves are damaged, so that's why. And then there are the points you went through, the skin changes around arterial and venous ulcers. So what's this? Yeah, here are the more common in. So long tortuous veins, superficial venous system. And normally the blood passes through the superficial system and the deep system at 3 sites. So they might have ischaemia-femoral, ischaemia-varix, so abnormality at the ischaemia-femoral junction. And then a lot of them get them along the back of their calves or their short saphenopoptail junctions. And there are valves to stop flow from the deep and superficial, and these are incompetent varicose veins. So that's why you get the tortuosity. Signs of chronic venous insufficiency, I think we talked about before in the picture. So edema, varicose eczema, hemosiderin, atrophy blanche, so like a white change to the colour of your legs. I don't think it's necessarily a vertical ulcer all of the time. And lipodermatosclerosis, so hardening, and telangiectasia. Management. The best thing to do for varicose veins most of the time is to leave them alone. A lot of women want them changed for cosmetic reasons because they are obviously not that attractive. But compression stockings, good treatment, and lose weight, regular walks, and avoid prolonged standing, because they're the big risk factors for getting varicose veins if you're overweight and if you're on your feet all the time. And then surgical things that they can do is stripping and stab avulsions. Just either they make a couple of cuts and pull the vein up, coil it up, pull it out through one of the higher cuts, and they make avulsions over the smaller varicose veins to release the pressure. It's quite brutal, and then you have to wear a bandage over your leg for 6 weeks, so it's not small surgery, and then most of the time they'll have a degree of recurrence. So necessarily getting them fixed doesn't mean they're fixed for good. So a lot of the time conservative management might be a better idea. And then if you have these dilated, tortuous veins, you catch them on something like the edge of a chair, you can bleed out of them, but that's quite rare.
Is the stab avulsion the same thing as having them injected? A patient said that they had them injected the other day.
No, injections are different. Injections are similar to sclerotherapy, what Jake was talking about for varices. It's sclerotherapy to your varicose veins, sort of reduces the flow in.
Presumably an intermediate step between conservative management and stripping?
Yeah, it is.
Okay.
And then superficial thrombotic is the last slide. So just because finals, they might bring it up, somebody comes with acute sore red hand, you're asked to see them in the ward, and you look and see that they've had a cannula there recently, or they might still have a cannula. So you basically remove the cannula, lift the limb up, compress it, and there's cream you can give them to make it fit better. But other than that, nothing to worry about.
Do you give them NSAIDs or analgesia?
If it's severe, if you're worried about it and think they might have, so a lot of times this cannula is tissued. They might have been getting stuff into it for quite a while afterwards, so it can be quite tender over where it's tissued. So yeah, if you give them NSAIDs, would be reasonable.
Is it the actual cannula that's caused it, or is it what they're running through it?
It depends. If you're running something really toxic to your veins, like amiodarone or something, that can cause intrinsic damage to the vein walls. And other times, if you just leave a cannula in for a certain amount of time, it's a foreign body. So if it's in there for long enough, it'll cause a local reaction that